is really important. So I am not going to lose my job. So if high risk for aneuploidies on NIPT, go in for invasive testing. NIPT again is a screening test, not to take a result based on NIPT. So one more test, but still we need amniocentesis. So we are moving forward and backwards both ways, but that's true. And the good news is the risk of miscarriage and amniocentesis done properly with things is actually reported to be much lesser now. We have been quoting 1 in 100 since ages. They are now saying quote 1 in 1000. So it's really not bad. And when not to do an NIPT, when you want a complete confirmation of the karyotype, when there are major structural defects in the fetus, when known karyotypic aberrations in the parents, if the parents have translocations, no role of doing NIPT. And presently it's still not widely available for genetic disorders. So if there are genetic problems, if there are karyotypic abnormalities, if there are structural defects in the fetus, better to do conventional karyotyping rather than it. Because you might rule out Downs and then the child might be born with some trisomy at 22 or something different. So the other thing is PCPNDT issues are not clear. So just to be on the safe side, get the forms filled. Get the PCPNDT forms filled, get it recorded, get it signed, and never allow them to reveal chromosome X and Y. And potential use is this rhesus typing should be available. All of you should start asking, because once you start asking, the companies will start thinking. And the future potential is genetic screening. So do you need fetal medicine specialists after all this happens? Yes, you need, because all these this is just for you to think that, you know, don't forget us. In twin pregnancies, the risks of Down syndrome always get added. So the actual risk is higher overall, but the method of screening is more scan based than biochemistry based, because biochemistry is a pregnancy specific test, whereas scan is a fetus specific test. So again, detection rate, maternal serum screening is 70%, nuchal translucency 70%, combined screening 85 to 90%, and all this non-invasive screening more than 99%. So the Fetal Medicine Foundation, this is just one lecture. Actually, it is free on the internet. If you go to the RCOG website, this is Professor Nicolaides' lecture on evolution of Down syndrome screening over the years. It's a fantastic lecture, about 43 minutes. And he just got some gold medal, Elder Holland gold medal or something. He delivered this lecture in November, and they put it on the RCOG website. It's free, you can just Google and see. Nice, the way the whole concept of screening has evolved. So this is what they are recommending, that you do the first line screening with the combined test. Because NIPT is expensive and it gives a false sense of reassurance. So better do a scan and a basic biochemistry first. If the result is more than 1 in 100, after a good screening test, then it's useful to just offer them invasive directly. If the risk is less than 1 in 2,500, then reassure them, don't bother about it. If it's between 1 in 101 to 1 in 2,499, then you can do the non-invasive screening test. And if that is also fine, then that's fine, no Down syndrome. If that is abnormal, then go for invasive test. So that is the protocol which we can follow here in India. Do a viability scan at 6 to 8 weeks, confirm dates, because all these screening tests are date based. So instead of going by the LMP, it's useful to have a 6 to 8 week scan. First trimester bloods, then NT scan. If you can't do that, then do all at the same sitting. Low risk, go for the anomaly scan. Anyway, in the anomaly scan, we will be looking at markers. So if any markers pop up, we'll look for it again. Otherwise, if everything is low risk, then fine. Down syndrome screening done. If first trimester is high risk, then they can either go for quadruple test or go for a CVS directly, or they can go for NIPT now. If after all that it is high risk, then they have to go for amniocentesis. If after NIPT it is low risk, then again reassure and continue as a regular pregnancy. So that's all about screening for Down syndrome. The target should be to start as early as possible and finish off this discussion by 20 weeks for sure. Because after that, even if we tell them something, we can't offer them anything. So that's the thing. Any questions? I'll be happy to answer. Ma'am, after 20 weeks, the law does not agree. So we cannot officially do it.
Suppose you have not diagnosed, the patient has not come before come 20 weeks. She has come at 22 weeks or 24 weeks, just borderline. Then you can do. Law does not tell.
The Act does not allow. If we chart it as 22 weeks, 24 weeks, then we can't. The only way you can do is
The documentation is on.
Documentation you have to do.
I have one question. So there are recently we've come across some. It's okay. Where the first trimester screening, let's say we had a high risk, and then mostly we would have